you to follow as a standalone. This portion is today I'm going to start with the torso, okay, and then tomorrow we're going to do everything above the neck, including the face. What I am doing this time that is a little bit different than the previous modules is that there is a lot more case studies, not just protocols, but actual stories of patients that I've applied these techniques for. So hopefully it will lead to a lot of fruitful discussion for everybody. Okay, so just to go over sort of the note package today, we have two separate packages. There is a package for the anatomy or the theory portion, and then there's a separate note package for what I call the treatment strategies. So I apologize, I will be jumping back and forth. I feel after teaching many years that it's good to keep the clinical right after what I've discussed a certain anatomical region. This actually reinforces the learning when you have some actual therapeutic connection to the basic science component of the anatomy. So during the various portions of the presentation today, I'll be asking you to leaf through to your protocol or strategy section so that we can keep it clinically relevant throughout this weekend. So what we're going to do now is we're going to start with the torso, the trunk. And the place that we're going to start this is at the level of the spinal cord. So this is why if you look at the diagram on the top right here, you will see a cross section of the vertebrae. And I want to point out a few salient features. First of all, you'll notice that the cross section labels this as cutting the body at the level of the fourth thoracic vertebrae. So we're in the thoracic spine, so that means we're at the level of the ribs. And this becomes important because running in between the ribs are what's called the intercostal nerves, right? Everybody knows that. There are intercostal muscles in between in the ribs are called the costals. And then so there are nerves around inside those muscles that are called intercostal nerves. But intercostal nerve is the name we give that nerve when it's in between the ribs. But what about the part of that nerve coming out of the spine before it enters between the ribs? There's a different name for that. That part of the nervous system is called the anterior rami. So if you look at this picture over here, you'll see that they have something called ramus labeled. Okay, ramus just means root in Latin. And so there's something called dorsal rami. If you follow my red laser pointer, there's something called ventral rami. And just for clarification purposes, ventral and dorsal are the same thing as anterior and posterior. Okay, so I believe now the preferred terminology is anterior and posterior as opposed to ventral and dorsal. But if you ever encounter that, or if I ever slip up and use terms differently, just remember that anterior is the same thing as ventral and dorsal is the same thing as posterior. Now, let's just help you orientate, look at this picture first. So this is your vertebral body, okay, and then that's your spinous process. So when we palpate count the levels of the spine, we're palpating the spinous process, okay, and so usually the points along the Neuro-Meridian will be in between these processes. So if you appreciate where the spinal cord is located, it's very well protected. Okay, and when the nerves come out in what's called the intervertebral foramen, these are just little bony holes that the nerves come out. So if you actually have spurs and things like that, or narrowing of these foramen, you can have something called radiculopathy. We'll talk more about that in the strategy section. So when the spinal cord exits this foramen, what's called intervertebral foramen, this nerve here, before it makes these fancy branching, it's called the spinal nerve. And it branches into three different roots. There's the ventral and dorsal rami we already mentioned, but there's one more, okay, and that is this guy over here. This is actually a sympathetic innervation. Do you remember in school we learned that sympathetic was the thoracolumbar, whereas parasympathetic was craniosacral? That's it's this guy that they're talking about when they're saying that sympathetic is thoracolumbar, because the level of the thoracic and the lumbar spinal cord, there's these branchings that come out here. So, and this actually forms its own vertical chain, not unlike the spinal cord runs top down. So you can imagine there's a spinal cord in the middle, and then two flanking smaller baby spinal cords that forms, that's called a chain, and that's your sympathetic nervous innervations to the various organs that are corresponding to those segments. During this presentation, you will also hear me talk about segmental input. So when we use that word segmental, you should be clear in your mind that that is a reference to the segments of the spine. And so if we say when you treat a lower extremity problem, let's say sciatic nerve, for example, right? Sciatic nerve comes from L5S12. So the segment for the sciatic nerve would be L5S12. And so we sometimes will say, you need to also treat it or modulate it segmentally. And what that means is that there will be some perispinal inputs or points at those corresponding levels or segments of the spine. That's what segmental means. Okay, so reflexively, how is it acupuncture can treat internal issues? Okay, I'm specifically describing the back shu points. So the back shu points usually corresponds to Zangfu organs, right? And if you look at where we are needling into the muscles. Back shu point will be the inner bladder line, okay? So 1.5 cun from the midline. So 1.5 cun from the spinous process, lateral on either side. So when we were to put a needle, as you can see, I put that down here, 1.5 cun, inner bladder. So if you follow the trajectory of the red arrow, where you're needling, you're into these muscle here. These are called erector spinae muscles, okay? Erector spinae perispinals, and we'll talk more detail about what those are. But they, in terms of innervation, if you can follow this arrow, this line here, where my laser pointer is pointing to, that's the dorsal rami. Okay, so that is not exactly stimulating the sympathetic segments, because I have already mentioned that the sympathetic nerve is one of 3 branches. So we are not actually needling into the sympathetic branch. So how then are we able to have a Zangfu effect? That effect is said to be a reflex, in the sense that if you follow this dorsal rami, they are nerves that innervate the muscles. So these are motor nerves, but these nerves also innervate the skin over here, okay? And the skin part are the sensory nerves. Okay, and so when you put a needle past the skin, you will stimulate the sensory nerve. That sensory nerve, as an afferent, will convey information distal to proximal, meaning going from the peripheral nervous system back to the central nervous system. So it creeps, the information goes back up, back into the spinal cord. And because it shares the same segment as whichever sympathetic Zangfu level or back shu level you want to stimulate, that information is processed and sent back out into the corresponding sympathetic chain or sympathetic segments. So what you need to appreciate is that the reason why it's called a reflex is that it's not a direct effect on the sympathetic nervous system. It requires that the afferent to bring the information back into the spinal cord. Spinal cord then spits it back out into the sympathetic segment. So, and that is how, at the level of stimulating the back shu points, has an effect on the internal viscera. It is through this segmental effect. Now, same thing would be true in terms of how we stimulate the points on the extremities. Okay, so going back to the example of the sciatic nerve once again. Okay, the sciatic nerve I mentioned is like alpha S1 2, right? And then if you follow the it's okay if you don't haven't reviewed the sciatic nerve. It's something we do a bit more in the lower extremity section, but for now, just do the best to stay with my explanation here. So the sciatic nerve goes down the lower leg, it eventually goes down to the ankle and goes down to the sole of the foot, and in so doing, it passes spleen 6, which is 3 cm above the medial malleolus. So how is it that we can stimulate the point like spleen 6 and have it have a gynecological effect? How can it have an effect on the bladder? It's because the sciatic nerve, which is in the region of spleen 6, comes back to alpha S1 2, and the sacral levels, S2 in particular, correspond to the parasympathetic innervation of the pelvic floor organs. So that information coming from the ankle, afferent goes back up to the lumbar sacral region, goes into the spinal cord, okay, and goes back out, down to the through the sympathetic levels. I want to just take a little pause here and say that perhaps spleen 6 wasn't the best example because, strictly speaking, remember I said craniosacral is parasympathetic. Here we're talking about sympathetic, but just play along and just understand the idea that things happen from a distal proximal, distal central, and then from the central back out to the distal idea. That concept is still the same. So once information comes back to the spine, it sends information back down into the sympathetic nervous system or the parasympathetic nervous system into the corresponding zangfu or viscera. And that's how, so this is why biomedically they call the effect of the acupuncture a somatovisceral effect. It required a somatic body stimulation through the afferents that comes back to the spinal cord, and as a reflex, go back into sympathetic or parasympathetic segments of corresponding organs. So, if you've always wondered, how is it, or especially some of our biomedical colleagues that don't truly appreciate how acupuncture can have, they might start to understand that acupuncture is good for pain. They heard about endorphins and things like that, but they don't truly understand how it can improve digestion, improve fertility, and as such, this is the type of explanation you can explain to them. In fact, there's also something going back to the spleen 6 example. In Western medicine, there's something called posterior tibial nerve stimulation, PTN, and that's actually something that a urologist will recommend, especially trained physio, to do this by the 2 electrical pads, and sometimes put needles too around the ankle and the arches area, and they know that doing that stimulation of the tibial nerve actually improves enuresis and incontinence, and what they're doing is really, in a way, acupuncture. And in fact, there's some information that suggests that the inspiration for this biomedical technique was actually from acupuncture. So this sets sort of the groundwork, even though we are focusing more on the orthopedic aspect of the torso and of the face and neck. But we should always remember that anytime we put a needle into the body, they will simultaneously have a sensorial afferent effect as well as some type of reflexive somatovisceral or sympathetic